Assalamu alaikum. This presentation is on vocal folds erythroplakia, the suspicious red patches on the vocal folds, particularly in high-risk patients like male smokers. Some known or unknown factors can lead to errors in the DNA and progressive accumulation of genetic changes in the laryngeal epithelial cells. This would lead to a clone of atypical cell in the epithelium. Some of these atypical clones could be self-limiting and would be abolished. Some would regress, some would persist, and others would progress into various other forms, including invasive squamous cell carcinoma. The whole spectrum from hyperplasia of the epithelial cells to various forms of dysplasia, mild, moderate, or severe, carcinoma in situ, or to invasive squamous cell carcinoma can be seen in different patients. Sometimes in the two or three of these can be seen in the same patient. The risk factors involved in the process include smoking and alcohol. Both are dose dependent, depending on the duration and the severity of the habit. Gastroesophageal reflux is also implicated. HPV may play a small, non-significant role in the process, but other idiopathic forms are not rare. Laryngeal dysplasia presents almost always in adults and affects men more often. It can present like a whitish or a red patch in the larynx, or sometimes a mix in between. It can affect any area of the larynx, but affects the vocal folds much more common, particularly the anterior half of the vocal folds. And it can be multicentric, affecting various other places in the larynx. Just by looking into the larynx by endoscopy could not differentiate between the various forms of this lesion. You cannot, by looking into the larynx, say whether this is keratosis, hyperplasia, mild, moderate, or severe dysplasia, or carcinoma in situ, or even invasive microcarcinoma. The reported rate for malignant transformation for these lesions, the laryngeal intraepithelial neoplasia, is anything between 1% and 40%, but identifying which patients will have this transformation into squamous cell carcinoma is not possible on clinical grounds. The term erythroplakia means a red patch that cannot be otherwise categorized or classified, whereas the term leukoplakia, the white patch, can often describe both benign and malignant changes like hyperplasia or dysplasia, mild, moderate, or severe. On the other hand, erythroplakia is usually seen as a pre-malignant lesion. The reddish appearance of the vocal folds, these reddish patches that cannot be otherwise classified, can be explained by the increased density of subepithelial vascular structures. These vascular structures, vessel loops, are secondary to new vessel formation associated with the tumor formation. In contrast, the leukoplakia is not a specific term. It describes characteristics of the lesion that ranges from being benign, like hyperplasia or keratosis, to severe dysplasia or even carcinoma in situ. The keratotic lesion may obscure the vascular changes associated with the tumor formation, the so-called the umbrella effect. You cannot see the subepithelial vessels here because of the keratotic lesion. But these blood vessels, new blood vessels associated with a tumor transformation, is characteristic in that they are no longer parallel to the long axis of the vocal fold. They are actually more or less perpendicular to this axis, and they are pointing towards the lesion like an indicator vessel. This is usually associated with early tumor formation. These perpendicular blood vessels, the indicator blood vessels, or ominous signs, even though the keratosis may be obscuring some of the vascular changes. There is still these seen perpendicular vessels are sinister enough. The two ill-defined terms could coexist. Leukoplakia can be seen in the same patient, combined with erythroplakia in as much as 15% of the cases. Some areas would have the keratinization and the whitish appearance of leukoplakia, and other areas would have the reddish hue of the erythroplakia. In general, very generally speaking, leukoplakic lesions have lower risk of malignant transformation. A mixed form between leukoplakia and erythroplakia have an intermediate risk, but a pure erythroplakia red lesion has the highest risk of malignant transformation. But none of these features, the whitish patches or the reddish patches, can be used as a solid indicator of the changes of the epithelium. Biopsy and histological confirmation and analysis of these lesions is still mandatory to determine their biological potential. There were some issues with the older WHO classification systems and some other grading systems as well. In general, classification systems should allow for a prediction of the biological behavior of a certain grade and provide guidance on the treatment or the follow-up for that particular grade. That wasn't the case with the previous WHO system, because there was considerable overlap between the rate of transformation to malignancy between the three grades and the duration it takes a lesion to be frank malignancy as well. That was the basis for the new WHO system, which basically has the laryngeal dysplasia classified into just two grades: low-grade dysplasia and high-grade dysplasia. The low-grade dysplasia includes only the mild or the minimal dysplasia, and the rate of transformation for this grade is just about 2%, whereas all the other grades, including the moderate dysplasia, severe dysplasia, and carcinoma in situ, were grouped as high-grade dysplasia, and here the malignant transformation rate is as high as 40%, ranging from 10% to up to 40% malignant transformation rate. The pathophysiology of laryngeal dysplasia is primarily abnormal epithelial differentiation within the laryngeal epithelium. There will be atypical cells and atypical differentiation within the epithelium. There may be also accumulation of keratin on the surface, and this will give the lesion its whitish appearance. Sometimes the epithelium would be thickened due to acanthosis, and this would give rise to a raised patch. But some other times there would be atrophy of the epithelium as well. The other feature may be seen in the subepithelial part is the formation of new blood vessels, sometimes perpendicular to the usually longitudinal vessels over the surface of the vocal folds, and this may be an early sign of a potentially malignant process. The change in the appearance noted in the erythroplakia is a combination of atrophy of the epithelium and lack of keratinization. This will give rise to the reddish appearance of the erythroplakia, while as the whitish patches are usually due to accumulation of keratin, sometimes accompanied also with a thickness of the epithelium, acanthosis. A certain growth factor called the vascular endothelial growth factor, VEGF, is strongly associated with new vessel formation associated with tumors or pre-malignant lesions. This vascular endothelial growth factor is produced in response to several things, some of them like oncogenes or inflammatory responses or cytokines or even tissue hypoxia are associated with tumor formation. It belongs to the family of platelet-derived growth factors that allows
the new vessel formation, endothelial growth that allows new vessel formation, and also stimulates its connection to the new cells formed by the tumor. This new vascular or microvascular lesion is the prime reason for the reddish hue of the vocal fold in cases of pre-malignant or sometimes the established malignancy. The top of these loops can be seen as dots over the vocal fold, and the reddish appearance reflects the increased density of subepithelial vascular structures. So when there is a process of malignant transformation associated with oncogenes and hypoxia, the produced vascular endothelial growth factor will stimulate the growth of new vessels from capillaries of the host towards the anoxic area in the new malignant transformation lesion. These new blood vessels would have very fine extensions, very fine tubes called filopodia that would ultimately fuse with corresponding filopodia from the tip of the tumor cells to establish a new microcirculation, giving blood flow to the newly formed tumor cells, and this would allow the tumor to progress. When this process is viewed from the surface of the vocal folds by contact endoscopy, particularly with narrowband imaging, you could see the newly formed loops of blood vessels between the host and the newly formed lesion cells or tumor cells. These will form loops called intraepithelial capillary loops, very fine loops near the basement membrane of the epithelium with the lesion. It is the hallmark of tumor growth, invasion, and metastasis. This is an early step in malignant transformation. The new vascularization is a multi-step process dependent on several factors, with some of them as dependent on overexpression of oncogenes and also the suppression of some of the genes that usually suppress tumor formation, like p53, for example. There would be some patterns to these newly formed blood vessel loops, and these patterns would be the basis for a new classification for the vocal folds or other epithelial pre-malignant or malignant lesions. This classification of the intraepithelial capillary loops is now utilized together with narrowband imaging to classify the tumor lesions and set out its prognosis. And Nye and his colleagues produced evidence to support their proposed classification in this very seminal article. Using the narrowband imaging, they were able to detect malignant or pre-malignant lesions with a fairly high sensitivity, almost 90%, and a bit higher specificity. They could show that their classification, their prediction from the imaging of the loops is closely associated with the histopathological features of the tumor biopsy. They confirmed that from type 1 to type 4 lesions, these are benign. Type 4 is usually a benign tumor like respiratory papillomatosis, for example. Whereas type 5 lesions are either pre-malignant in 5A or malignant in 5B and 5C. With the 5A, the pre-malignant, the carcinoma in situ, they have a remarkably high sensitivity, almost 100%, and less specificity, almost 80%. On the other hand, with the established carcinoma in type B, 5B and 5C, the specificity was 100%, but the sensitivity was a bit lower at around 83%. And here are examples of pre-malignant lesions like carcinoma in situ or erythroplakia, which resembles type 5A. You could see the lesions on the vocal fold surface, and you could see the narrowband imaging of the loops, which show solid intrapapillary loops, fairly symmetrical in their distribution. These solid loops can be seen clearly because the epithelium is still fairly translucent, and you can see the deeper layers of the vocal fold, including these loops. And the so-called erythroplakia, which describes a reddish appearance as a pre-malignant lesion of the vocal fold, you are actually seeing these vascular loops.
Patients with laryngeal dysplasia primarily presents with voice changes. They would require, of course, a full history and examination of the head and the neck. But the patients with a benign keratosis or just hyperplasia with no atypia would have the same signs and symptoms as patients with severe dysplasia or carcinoma in situ. There would be roughness of the voice and strain in voice production with a reduced dynamic range. The gold standard in the examination is laryngeal endoscopy, either flexible or rigid. Better still if can be combined with video laryngostroboscopy if it's available. Anterior commissure area and the ventricles and the undersurface of the vocal folds need to be assessed, and this can be assessed with various angled rigid laryngoscopes, for example. Trying to distinguish between a low-grade and a high-grade laryngeal dysplasia can be improved by the use of the bioendoscopic techniques, such as the narrowband imaging system or the SPICE system. This will show the architects of the blood vessels in the subepithelial layer and high precision photography of the laryngeal epithelium. If certain abnormal blood vessels are seen in the vocal fold subepithelial layers, like intraepithelial papillary capillary loops or vessels perpendicular to the usually longitudinal blood vessels on the surface of the vocal folds, this may indicate some potential for malignant transformation. The accuracy of such systems of the bioendoscopic techniques is quite high. It's about 83% for sensitivity and 98% specificity for the narrowband imaging, and quite similar results for the SPICE system. Laryngeal stroboscopy, if it is available, can be of help in defining the depth of the lesion. It can show whether the lesion is restricted to the intraepithelial part and can move freely with the mucosal wave, or it has some deep invasion into the lamina propria. And this would be of help in the grading and in the management of such lesions. If the lesion is very superficial, limited to the epithelium, then it will give the appearance of a boat riding on a wave during stroboscopy. But if there is any deeper invasion, there would usually be involvement of the mucosal wave and the vibratory amplitude of during stroboscopy. The mucosal wave would stand still at the part which is relatively fixed to the lamina propria. The management of laryngeal dysplasia should start by a trial at reducing the risk factors. Medical treatment currently does not have a significant role in the management of laryngeal dysplasia. There were reports of some benefit from aspirin, metformin for non-diabetics, retinyl palmitate and folate, but there is no solid confirmation of benefit. The reduction of the risk factor should start by trying to stop smoking. However, if the lesion had reached the grade of severe dysplasia or carcinoma in situ, the lesion may be irreversible. Before that, in mild and moderate dysplasia, there are reports about lack of progression and sometimes reversion of the lesion after stopping smoking. However, stopping smoking is useful to prevent further recurrences after the initial treatment. Alcohol should also be reduced or stopped. laryngopharyngeal reflux should be treated. At this stage also, the patients would have to be counseled about the effect of the management on their voice and about the potential for malignant progression of their lesions. The best scenario would be a one-stage surgical excisional biopsy of the entire lesion. This would remove the whole lesion without a need for any second stage surgery, will provide the pathologist with all the available material so that he could reach a proper diagnosis and grade the lesion, and also would not affect the intermediate and the deep layers of the lamina propria so that the effect on the voice would be minimal. The excised lesion should then be properly orientated before sending it for pathological examination, marking where is anterior, where is posterior, lateral, and medial. If the lesion is confined to the epithelium and does not have any signs of deep invasion, then a complete excisional biopsy could be achieved as a one-stage procedure, ideally with a carbon dioxide laser. The UK consensus statement on the management of laryngeal dysplasia favors excision biopsy of the laryngeal dysplasia lesion by the use of carbon dioxide laser, although cold steel excision can give comparable results. The benefits of using carbon dioxide is a better control of the surgical field and less bleeding in addition to precise incisions. The use for laser to ablate the lesion rather than excise it is discouraged, as it would have collateral damage to the lamina propria and the voice, and will also destroy material that can be useful for histological examination and grading of the lesion. Vocal fold stripping is not recommended. If the lesion is primary, that is a new lesion with no previous history of recurrence, then the use of radiotherapy for the treatment should be offered only with discretion, only in very selected cases like poor access and visibility of the larynx, or when the resection has a high risk on a patient with poor health. Currently, the only indication for open partial resection and biopsy would be a very inadequate exposure of the lesion by endoscopic route. In new laryngeal dysplasia lesions that had not been treated in the past, the most important factor in deciding the type of management would be whether the lesions are localized, whether they are single lesion or multiple localized lesions, or whether the lesions are widely spread over the surface of the vocal fold. If the lesions are localized, whether single or multiple, then they can be excised completely in a single stage type of surgery. Each of the excised lesions would be marked and orientated. But if they are widespread and confluent, then complete excision may not be possible in a single stage. The lesions would have to be mapped and staged. After mapping the lesion, a part of the vocal fold epithelium would be removed with some of the lesions, and a second stage may be required at a later stage. Of course, the general fitness of the patient will play a role in the decision making. The management of persistent or recurrent laryngeal dysplasia lesions would depend on two factors: whether the lesion is localized or widespread, and whether the lesion is low risk or high risk. If the lesion is localized and low risk, then the management is re-excision. If the lesion is localized and high risk with severe dysplasia or carcinoma in situ and recurrent, then the management should be similar to excision of a T1 laryngeal carcinoma with subligamental cordectomy, a type 2 type of cordectomy, or higher if needed, if there is invasion deeper to the ligament layer. But if the lesion is widespread and low risk, the management would depend on weighting the benefits against the risks. There are risks involved with excision of widespread lesions on the voice, and the patients can be either observed for a while. If the lesions are not progressive, then they can be observed for further periods. But if there is any fear about progression of the lesion, then the patients may have excision, surgical excision of their lesions. But if the lesion is persistent and high grade and widespread, then the patient should be offered radiotherapy. There are other indications to consider radiotherapy that we're going to discuss later in this presentation. The outcome of these treatment modalities were investigated by a recent meta-analysis that showed that the local control rate for radiotherapy is high at 93-point-something%, followed by carbon dioxide laser excision at 80%, and then vocal fold stripping at 77%. The differences were statistically significant. The ENT UK guidelines for the follow-up frequency and duration for laryngeal dysplasia patients are based on two factors. One is whether the lesion is low grade or high grade, and two is whether the patient have continued any risk factors or stopped smoking and alcohol, for example. If the lesion is low grade and the patient has no risk factors, then he can be followed up for 6 months. But if the lesion is high grade, or if the patient continues to smoke or drink, then the patient would be reviewed in the same way like a T1 carcinoma of the larynx. And each examination, he would have laryngeal endoscopy, whether flexible or rigid, and a color photo would be obtained and documented in his notes. The patient would also have a neck palpation in each visit, and he will be asked whether he still smokes or drink, or whether there is any other risk factors. The two recommended techniques for adequate excision biopsy of laryngeal dysplasia are either a type 1 subepithelial cordectomy or a type 2 subligamental cordectomy, depending on the depth, the extension of the lesion. If the lesion is confined to the epithelium with no invasion in the depth, and after injecting saline into the subepithelial rhynchus space, the whole lesion is lifted off the vocal fold ligament, then a type 1 subepithelial cordectomy is the preferred technique, in which the epithelium with the lesion in it and part of the subepithelial layer, the rhynchus space, sparing the vocal ligament with the intermediate and the deep layers of the lamina propria, would be the preferred technique. It does not have to extend in the entire vocal fold length from the vocal process of the arytenoid to the anterior commissure if the lesion is confined only to a small part. By lifting the epithelium by saline infusion, the accuracy of detecting any depth of invasion is raised from 60% to 90%. But if there is doubt about the deep extension of the laryngeal dysplasia lesion beyond the laryngeal epithelium, like if there is loss of the mucosal wave on stroboscopy, or if the saline infusion into the subepithelial layer intraoperatively fails to elevate the lesion completely off the vocal ligament, then the recommended technique would be a type 2 subligamental cordectomy. And this, not only the epithelium and the superficial layer of the lamina propria would be excised, but also the intermediate and the deep layers of the lamina propria, forming the vocal ligament. And if required, if there is extension into the muscular layer, also a strip of that muscle would have to be excised. This is the type 2 subligamental cordectomy, which is the preferred technique for microinvasive carcinomas and for recurrent, either severe or carcinoma in situ recurrent laryngeal dysplasia. And finally, if there is any role for radiotherapy in the management of laryngeal dysplasia, radiotherapy should be considered in the following circumstances. If the patient had 2 or more recurrences, if the patient continues to smoke, if the patient has high risk of anesthetic problems, if the patient has some difficulties in laryngeal exposure or access in endoscopic laryngeal surgery, if the patient prefers to have radiotherapy, and in the patients who have persistent or recurrent widespread severe dysplasia. By this, we come to the end of this presentation.
on vocal folds erythroplakia. Assalamu alaikum.